to FGR, SGA, and reduced fetal movement EMQ shots. There has been a huge demand on it, so this is on special demand. So here we talk about the very important guideline, that is the SGA guideline, and last few slides will be dedicated to the reduced fetal movements. So by definition, it is very important to understand that small for gestational age and fetal growth restriction. So small for gestational age is basically the estimated fetal weight or the abdominal circumference is less than 10 centile, while fetal growth restriction is either this is less than 10 centile, but there is some Doppler abnormality, or it is just simply less than third centile. To understand this definition, it is very, very important. Now, monitoring as per risk factors of fetal growth restriction monitoring. So in any question of SGA is basically, first is you have to define what is the risk, and then according to risk, what kind of monitoring is required, and according to that monitoring findings, when to deliver. These are important steps in these questions. Now, first thing is to define risk. To define risk, we divide them into three categories: low risk, moderate risk, and high risk. Low risk is we will not do anything, just simple serial measurement of symphysiofundal height, that is from 24 weeks onwards, at least at 2 weekly intervals, and we'll reassess at 28 weeks if the risks have developed. Now, moderate risk is, what are the moderate risk factors? Like previous SGA, previous SB, but baby was fine, weight was fine, appropriate for gestation age, SB, drugs, and smoking history. Now, any time, any cigarettes, any number of cigarettes is included in it. Age more than or equal to 40. Remember, it is equal to 40 as well. BMI less than 18.5. What is in these cases? It is 32 weeks. Low risk, moderate risk, we will start from 32 weeks. Every 4 weekly, we do the scan. Now, high risk is, in high risk, what are the patients included here? Current SGA, previous SGA stillbirth, medical disorders like blood and ultrasound markers. So here blood and ultrasound markers will include like echogenic bowel, then your PAPA value, high PAPA value, low PAPA values, high inhibin values. These will be included in this, and significant bleeding. From 28 weeks for congenital uterine abnormality, and from 32 weeks for BMI more than or equal to 35, or fibroids are there. So this is your categorization, how you categorize. Now, how to monitor? It is important to understand that Doppler is done weekly, but biometry is done only fortnightly. If you understand the reason behind it, that the growth will be significantly changed in 2 weeks. So at least we have to do in 2 weeks to understand this. Now, Doppler changes are defined as what kind of a Doppler changes you can expect. If it is PI more than 95th centile, then this is a borderline change. If it is absent end-diastolic flow, it is pre-critical. But once this becomes reverse end-diastolic flow, this becomes critical. So umbilical and the ductus venous Doppler and the CTG monitoring is finally done to make a final decision. So if it is the borderline change, that is only PI above 95th centile, then we will keep on monitoring weekly. If it is a preclinic critical one, that is absent end-diastolic flow, then we will do alternate day. But if it is a reverse end-diastolic flow, then we have to do it daily. What about the MCA use? MCA before 37 weeks does not have any use. After that also, we can use this abnormal MCA, CPR, or umbilicocerebral ratio to be as a guide for timing the birth. But up to 37 weeks, it is not taken as significant. Now, what is the delivery time? SGA. SGA without any Doppler problems can go up to 39 plus 6 weeks. FGR, maximum if all normal, then maximum is 37 plus 6. Once it is labeled as FGR, that is SGA with Doppler changes will also come in this category. So at 37 plus 6, you terminate. If it is borderline changes, that is raised PI, you terminate at 36 weeks. If it is pre-critical, that is absent diastolic end flow, then it is 34 weeks. And if it is a reverse flow, then it will become 32 weeks. Now, in cases of SGA or late FGR state fetus with normal umbilical artery Dopplers or abnormal with end diastolic velocities present. Now, it is not absent nor reverse. Still, the velocities are present. So, patient can go for vaginal delivery. Induction of labor can be done by mechanical methods, but rates of unplanned cesarean birth are increased. Abnormal CCTG, STV, DV alteration, or umbilical artery, absent or reverse and diastolic flow, cesarean after administration of steroids and magnesium sulfate is the correct answer. Of course, magnesium sulfate and steroids will follow their rules as per the NICE preterm guideline. At 36 weeks, the scan showed, now these are few questions. At 36 weeks, the scan showed estimated fetal weight at 10 centile with normal Dopplers. How do you want to monitor further? Now, this is estimated fetal weight at 10 centile. It hasn't entered the pathway even. Everything is normal. It's a normally growing fetus. So, let delivery happen spontaneously. So, spontaneous delivery is the correct answer. A 28-year-old primary gravida with the cocaine user, now this is the drug use, moderate risk factor, has come to 28 weeks period of gestation. What is the ultrasound surveillance? So we know that in moderate, it is basically the ultrasound today, that is 28 weeks, and then 32 weeks onwards, because at this point of time, we need to see what is the SGA, what is the growth like, and then from 32 weeks, every 4 weekly. So ultrasound today and then 4 weekly is correct answer. SGA less than third centile with normal Doppler at 29 weeks. She had the same findings at 20 weeks, but never investigated. Now, this was early onset SGA, right? Early onset FGR actually, because less than third centile is there. So, more likely to be chromosomal. So, therefore, offer amniocentesis is the correct answer. 41-year-old primary gravida smoker who came at 16 weeks of gestation and showed her worries regarding her chance of having a small baby. Her friend recently delivered a very small baby. Do we do the screening just because she is worried? No, but the risk factor is 41 years. So moderate risk factor. So serial assessment of the growth scan from 32 weeks onwards. 29-year-old woman at 36 weeks period of gestation with IUGR with umbilical artery Doppler showing normal pulsatile index, normal middle cerebral artery Doppler. What is the next line surveillance of ultrasound that needs to be done for this patient? So everything is normal. So just as I said, fortnightly growth and weekly Dopplers need to be done. This is a bit about the reduced fetal movements. So what to do? Initially, when a patient comes to you, you have to do a risk assessment. On top of this, in the guideline, you can see the risk assessment there. So always you have to do the risk assessment. Next step is to go for the auscultation with the Doppler. Now, if you find the fetal heart with the Doppler, you can do the CTG. And if the CTG is normal, then just reassure the patient. And if she comes again, continuous RFM stays there, then ultrasound is the next feature. Ultrasound is not routinely done for every patient, right? Now, if the CTG is suspicious, you will manage as per protocol. Or if the fetal heart is not heard, then it is going towards the IUFD, and accordingly, you have to manage. Now, 32-year-old primary gravida presents to the antenatal clinic at 32 weeks of gestation with her first pregnancy. She reports experiencing a reduction in fetal movements over the past 24 hours. What is the most appropriate next step in the management? So, as I said, whenever the patient comes, next step is take history. So, detailed clinical history, including the risk factors. Now, if this is not next step, if it is the most appropriate step, then your answer will be auscultate by the handheld Doppler. That's how RCOG plays with you. IUFD at 26 weeks, appropriate dose of mifeprostone followed 24 to 36 hours later by misoprostol. So it is basically you are going to give 200 milligram mifeprostone and then 200 microgram of the 4 doses QDS, that is 4 times. So total mifeprostone plus 4 misoprostol will become 5 doses. So therefore C option is correct. Mifeprostone 200, meso 200 microgram and QDS total 5 doses. And these are the various doses which we can use from 24 to 26 weeks. It is 400 micrograms, 25 to 27 plus 6, it is 200 micrograms. And 28 onwards, it is 25 to 50 micrograms vaginally every 4 hours. A patient have a previous scar with IUFD. Why is a mifepristone given before misoprostol? That shortens the delivery time by 1 hour. So all dreams are within reach. All you have to do is keep moving towards them. And that's how the mrcoG courses is always with you. Thank you so much for your patient listening.